Okay, it's 5 o'clock, so I think we should kick off. My name's Adam Fox. I'm currently the president of the British Society for Allergy and Clinical Immunology. I just wanted to take this brief opportunity to welcome all of you to what's going to be the first of a series of webinars. What we really wanted to do is build on the engagement that we got through the summer when we ran a series of COVID webinars, where we got fantastic attendance and real benefit from getting together as a large group, and realised that we probably should have been doing this for ages beforehand. I really wanted to thank, firstly, Rubaiyat Haque, who I'm going to hand over to in a second, for taking the lead on this and being the organiser of these events. And also like to thank Bob Boyle as well for putting his hand up to be first. Somebody's got to volunteer, so great that he has, and very much appreciate that. I'm going to hand over now to Rubaiyat, who is going to introduce the series, and just encourage everybody, whatever they feel, whether this went well, not so well, how they think it should go in the future, please do let us know. Drop us a line directly to the BSACI office, or myself personally, or to Rubaiyat, as we're really keen that this develops into something that everybody wants to be a part of for a long time to come. Thanks very much, Rubaiyat.
Thanks, Adam. Thanks very much. Just to give you a bit of an outline of the series of webinars that we're going to organise over the next year. This is going to be an event that occurs once every 2 months, usually in the last week of the month. There'll be individual council members organising each particular one, but what I'd like, if it's all right with you guys, is any suggestions as to what particular topics might be covered. In the chat, I'll put my email contact details, so please feel free to get in touch with me if you've got any ideas of what particular areas you want covered. And also, if anyone's particularly interested in leading one of these webinars, then again, please let me know. Also, thanks very much to Bob Boyle, who stepped in at very short notice to do this first one, along with the team of speakers. So I'll hand over to the first speaker, who I believe is Hilary Allen. Thanks very much.
Thank you very much, and I'm delighted to be here tonight. I'm just going to try and share my screen. So my name is Dr. Hilary Allen. I'm a GP practicing in the west of Ireland, and I have a special interest in allergy. I provide an allergy service in primary care to which other GP colleagues refer their patients. So just to say that I've no disclosures to make, I'm going to present 2 cases that would be very typical cases of what I would see presenting with suspected milk allergy in my primary care practice. I'm then going to ask you as an audience to vote on how you would manage these cases. And then I'm going to address some of the uncertainties I see in women who present to me, but also the uncertainties I feel as a clinician in primary care managing these cases. And then I'll hand over to my colleagues maybe to address these uncertainties. So the first case that I have is a breastfed baby, 2 months old, growing normally. There's no family history of atopy, but mum's 2 nieces did require a special formula. That she presents to myself with crying, vomiting, and mild eczema, and this has resulted in multiple visits. Just by way of background, mum has no medical illnesses, but there was a history of anxiety in adolescence and a possible eating disorder. The mum is extremely socially isolated. Her partner works nights. She has no family nearby, and she relies on the online parent forums for helpful parenting advice. And indeed, this is where she has learned a little bit about allergy. So her question to me when she attends is whether she's harming her baby by continuing to breastfeed, that this might be the cause of her eczema. So my questions to you is, how would you manage this? So A, would you treat the eczema and reassure the mother? Would you B, continue breastfeeding, but advise maybe a trial of dairy exclusion from the maternal diet and then reintroduce after 1 month? C, would you advise discontinuing breastfeeding and commencing a hypoallergenic formula? D, would you screen for postnatal depression, refer for breastfeeding supports, review her eczema management, and reassure the mother that this is not likely to be underlying an allergy? Or E, would you commence anti-reflux medication? So I'm going to move on to my next case. I think we have quite a lot of votes in there. Most people have voted. So my second case is a formula-fed infant. So 3 months old, presents with vomiting, crying at night, bloated stomach at night, seems to be in pain, too unsettled to feed at nighttime. Parents have tried several formulas, including repositioning, and they haven't slept in 3 months. Of note, there's no red flags, so no bile-stained vomit, failure to thrive, no developmental delay, no severe eczema all over the body, and no blood in the stools. And this child is meeting his growth centiles. So again, how would you manage this case? So would you A, refer to a pediatrician? Would you B, reassure and advise the mum that this is normal infantile behavior such as colic? Would you C, stay on the same formula but prescribe an anti-reflux medication? Would you D, advise changing to amino acid formula because these symptoms are severe? Would you E, change to extensively hydrolyzed formula and avoid all dairy with reassessment at 12 months? Or F, ascertain if the symptoms began soon after introduction of the formula, and if so, consider an extensively hydrolyzed formula with reintroduction after 1 month. So, in terms of uncertainties, I find an awful lot of women present to me with uncertainties about allergy with regards to their baby. So the questions that I hear them saying to me is their breast milk causing their baby's eczema, or should they eliminate dairy from their diet? Often they'll have already started the process of elimination, and then if they don't see any improvement in the eczema or the vomiting or crying, they'll start to feel that maybe they weren't strict enough with their diet, and I'll hear statements like, I had a couple of biscuits made with milk and that's why they were unsettled that night. I'm often asked, should they change to a special formula? I also see quite a bit of anxiety or concerns about weaning and introducing other allergen foods such as eggs or nuts. But mostly what I see is that women are quite overwhelmed by all the different information that's out there. And they'll often say to me, I just don't know what I'm supposed to do. And they want to know for certain, is it allergy or not? Likewise, as a GP, I also feel quite a bit of uncertainty about managing these cases. So in particular, am I getting the right diagnosis? So is this normal infantile behavior, or could this be a mild form of allergy? And I think it's very important to remember in primary care that the vast majority of patients presenting to us are clinically well. And so they often present just with health concerns rather than with actual definite disease or illness. And there's also a social context to those presentations. So in my first case, I wanted to emphasize that this mother had had a previous history of anxiety with an eating disorder. So for me, making a decision about eliminating dairy from that woman's diet is quite concerning, because I don't want to create any additional stress around eating in somebody who has previous history of an eating disorder. And likewise, I emphasized in that case that she was quite socially isolated. And so the online forums were actually quite an important support for her, although she was getting a lot of allergy information and possibly not correct information from those sources. So I also have concerns regarding the implications of missing an important allergy diagnosis. So if my patient, if I tell them it's not allergy and then they go to another doctor or a pediatrician and they're told it is allergy, then obviously that's quite confusing, or they may be very dissatisfied with me. And there's also a professional competency issue with that. When I have to consider whether to put somebody on a specialized formula or advise dairy limitation, I have concerns whether I'm undermining breastfeeding. I have concerns about nutritional deficiencies that have been reported in exclusion diets. I'm also concerned about the impact on future siblings. So I will often have women say to me, if I have a future child, should I just straight away go ahead onto a hypoallergenic formula? And in that context, maybe breastfeeding isn't even considered. I have concerns about the psychological effects of applying an allergy label and the stress created with exclusion diets. I'm also concerned about the cost. So certainly in Ireland, some parents have to pay for specialised formulas at significant cost. We know there's a cost to the healthcare system. So in 2016, I believe the cost was in excess of 60 million to the NHS. But my biggest uncertainty as a GP managing these cases is, am I doing harm to my patient if I prescribe an unnecessary exclusion diet or a specialized formula? So although for me, it seems quite easy to prescribe these or to have a trial of a formula or a trial of an exclusion diet, it's not without consequences. And that's something that I always consider with every patient that comes into me. So on that note, I would like to hand over to my colleagues that hopefully will address some of these uncertainties, and we will come back to the answers of the polls in our Q&A system at the end. So I'm passing on to Michael now, and I'll stop sharing my screen. Thank you very much.
So I hope you can all hear me satisfactorily. Danny, you can nod if you can hear me, which would be good. Brilliant. Someone seems to be living underneath the M25 flyover, so whoever that is, if they want to mute themselves and possibly save up for a new house. So anyway, it is a great pleasure to be invited by Bob to come and give a talk in this webinar. And I've been asked to address the issue of the relationship between common symptoms during infancy and cow's milk allergy. Now, I think I've forgotten a disclosure slide, but I have nothing to disclose. So let's see if I can move on. I love this. This was Bob's addition to our recent paper with Daniel, and it's this Shakespeare quote: "And one man in his time plays many parts, his acts being seven. At first the infant, mewling and puking in the nurse's arms." And if Shakespeare was capable of recognizing that what infants do is mewl and puke, it shouldn't be a surprise that that is an activity that the rest of us notice as well. So everyone listening to this, I'm sure, is aware of the fact that I was the co-principal investigator on the EAT study, and you've heard all about EAT many times before, but the opportunity arose in the area of investigating the association between common infant symptoms and potential milk allergy was potentially to utilize the wealth of data in the EAT study to address this issue. And this largely pertains to the fact that the EAT families were heroic. They completed monthly long questionnaires, including extensive details about symptom reporting, monthly between 3 months and 12 months. And then between 12 months and 36 months, they did that 3 monthly. They did a couple of extra ones at enrollment and food frequency questionnaire, but it meant that the participants in the study were filling out 19 really quite comprehensive detailed questionnaires during the course of the study. Now, what's useful about that, it allows us to look at the frequency of reporting of common infant symptoms. Now, I'm using the adjective common there because it's exemplified in this figure. So what you're seeing here, and you'll see in the next couple of subsequent slides, we presented this data, in fact, in the New England Journal in our supplementary appendix, but it was buried fairly deep, so some of you may not be familiar with it. So every month, the families were asked to report how frequently they reported their infants to be exhibiting a certain symptom. This one in question was positing. And you can see the categories that were available, starting with the most frequent one, as in more than daily, then diminishing to daily, to 5 to 6 times a week, 2 to 4 times a week, weekly, and monthly or less. And you can see that when it comes to positing, it's divided into the early group and the standard group. And of course, we were doing this largely around looking at the prevalence of side effects or potential side effects of early allergenic food introduction between the two groups. But where this data has got immense value is for precisely this kind of issue of looking at the association between these common infant symptoms. And in fact, we can look very elegantly at the association with milk consumption. And you can see that certainly in these early months of life, positing is ubiquitous. It is what infants do. They puke, as Shakespeare accurately identified. Now, of course, we might all be comfortable with the idea that infants posit. The question is, when does a posit become a vomit? This is a bit like, when does a petechiae become a bruise? So it's a fairly sort of subjective issue between both parent and doctor. But anyway, we did separately ask about the frequency of reported vomiting. So I want you to notice the scale here going up to 100%, nearly 100% reporting it in those early months. When we switch to vomiting, so the scale's dropped here, the peak now is at 60%. Now notice that in the early introduction group, we get an excess of reporting of vomiting. And this is, I think, largely related to the fact we were asking the parents to watch very meticulously whether their children were happy, infants happy eating these 6 allergenic foods that they were being asked to eat in quite a big quantity. So perhaps more relevant is to look at the standard group here. But you can see that even here, we're approaching 40% of infants, the families are reporting vomiting. Now, probably worth emphasizing the threshold that very regular vomiting. So if we take regular vomiting as meaning more than daily in blue here, or daily, you've still got a reasonable minority of infants reporting vomiting on a frequent basis. What about colic? Again, it's one of the ubiquitous ones. Remember, the EAT infants enrolled at 3 months of age, so I can't tell you about the symptoms before 3 months, but if anything, it's likely to be even higher in those early months. But again, this is interesting because it shows a very rapid diminishing over the early course of the first year of life. But in those early months, it's pretty highly significant. What about diarrhea? We asked the families to report in the interim questionnaires how many days they reported their infants as suffering with diarrhea since they've completed the previous questionnaire. So this is every month, and you can see that on average is about 1 day a month. A family is reporting that they felt their infant had diarrhea. We didn't define it further. We left it at the parents' discretion to determine what they considered diarrhea. These are now in 3 monthly intervals, and you can see that there's about sort of 1.5 to 2 days a month or so. Same with constipation, half a day to 1 day a month, and then about the similar frequency beyond a year of age. So you can see that infant symptoms are extremely common. So the question then arises, so that's about sort of common infant symptoms. What about symptoms in association with specific allergenic food introduction? Now on this one, we're switching to the early introduction group because of course it was the early group that were asked to introduce milk before 6 months of age. And so this is now columns for the 6 foods, and then on the right we've got any symptoms of any of the foods. We're dividing up into the 3 principal early months of introduction: 4 months, 5 months, and 6 months. The bottom one row is for a composite of all the early months from 4 to 6 months. And then we divided the symptoms, I did, based on translating the parents' free text report of what symptoms they had observed in their infant. I determined whether I felt that it was more consistent with an IgE type, a non-IgE type, and then we've got a category for IgE or non-IgE type. What I just want to draw your attention to is that when we look at the composite of 4 to 6 months and either type of symptom, you can see that egg is the predominant food. This is the early introduction group. It's about 650 children. So, but remember, this is an early introduction regime. So obviously the number is going to be somewhat inflated because families are actively looking in these infants to see if they observe symptoms. But what I want you to observe is that egg allergy, widely regarded as the most common confirmed food allergy in children, is the biggest, but only marginally behind is milk, with 63 cases for IgE or non-IgE. When we look at IgE alone, you see egg as the predominant condition that's been reported. Interestingly, peanut, which we're giving to these very young infants, it's the lowest of these 3 here for both IgE or non-IgE, lowest for IgE. But it's really the bit that, as always, is causing us the most angst is that when we come to the non-IgE symptoms, we see this big excess. We saw it in the BEAT study. You see it again and again, is that this absolute disproportionate excess of suspected symptoms, non-IgE type with milk. 46, by far and away the biggest in that row. And of course, that's got to be set in the context that milk allergy, now I've switched to the standard group now, because of course, then there's no possible confounding by the efficacy of the early introduction regime. But you can see here just how rare this is IgE confirmed milk allergy in the standard introduction infants in the E study, how rare milk allergy was, 0.7%. And yet that compares with the symptom reporting we just saw on the previous figure. So when we put that all together, and this is, I think, a really nice figure that comes from our paper that we did, this is the combination of, again, now in the standard introduction group infants, of 3 Venn diagrams. And what the Venn diagrams are showing is that amongst the 650 standard introduction group infants, it's saying during the first year of life, how many at any point in the first year of life reported vomiting at least daily, or in the middle one, colic at least daily, or in the final one, this is parent reported eczema in any of the interim questionnaires. And these are proportional Venn diagrams. So the area represents the number of individuals in the standard group that were positive for these different things. And you can see that these symptoms were incredibly common. Diminished slightly by when we asked how many children, well, the number diminishes slightly when we asked how many families in the standard introduction group suspected their infant of having milk symptoms, just like I showed you before, but this is all the way through to the first year of life. And you can see that milk symptoms are frequently being suspected, but interestingly, the overlap between the vomiting and the milk symptoms is actually relative. It's only a minority. So many people are suspecting milk symptoms, but not reporting vomiting. Finally, we have this 0.7% here, which is the proportion that have proper challenge confirmed IgE mediated milk allergy. Now, you might obviously be asking, it's not non-IgE mediated, but there's good data to suggest that the prevalence of non-IgE mediated cow's milk allergies of the order of IgE type milk allergy as well. So just what's extraordinary is to see just how small this is. And again, the fact that there is individuals that have milk allergy with, interestingly, neither the family suspecting any milk symptoms or, for that matter, having vomiting, and sort of each combination as well. Interestingly, with colic, there was no overlap between the milk allergy where it occurred and the kids having colic. Eczema, because eczema is so prevalent, obviously it's overlapping there. But really, the take-home message is the disproportionate nature of the symptoms to like vomiting, colic, or eczema versus the real excess of suspected milk problems versus true milk problems. Now, in the original figure we submitted to the journal, we actually included the purple squares, which they, for some reason, chose to leave out, which is actually the proportional size of the full standard group. So that gives you the full representation. You see for eczema, virtually all the kids in the study were, half of the kids or so out of the standard introduction group were having eczema reported at some point in the first year of life. These are almost like rites of passage symptoms. So that wealth of data that we have collected within the EAT study renders an opportunity, and this is something I'm now pursuing with Matt Ridd, who's an academic GP outside of Bristol, with a lovely research fellow that he's had working with him for 3 months, Rosie Vincent. And what we've realized we're able to do is to take symptoms from one of the diagnostic tools that's frequently used, and we've mapped this against the EAT study questions and the interim questionnaires where we were able to ascertain these symptoms. And for most of them, we can have a pretty good stab at including virtually all the symptoms that are reported. So what we have done is use the EAT data to generate a report of how many symptoms from this particular diagnostic tool were being recorded each month within the standard introduction group participants in the EAT study. And so how many would have exceeded the threshold for it being suspected that they had a milk-related issue. So that we've done this now. It's been 3 months of work, which Rosie's done very elegantly, and we literally just wrapping it up now. But it's absolutely fascinating. This is going to be going for submission shortly, but it doesn't take a rocket scientist to work out perhaps what it's going to suggest. So take-home messages. Prodigious quantities of infants mule and puke. That's what they do. They also have diarrhea, constipation, eczema, colic, food refusal, feeding difficulties. That's also what many infants do. Milk's disproportionately suspected as being the cause of non-IgE type symptoms in infants. And true cow's milk allergy, and that's whether it's IgE or non-IgE type, is uncommon. So we should be, I think, as a body, striving to avoid overdiagnosis. But how we restore the balance is uncertain. And I think that's going to be the subject, hopefully, of our discussions. So thank you very much.
Thank you very much for having me here today. And thank you very much for Bob for inviting me. It's such a pleasure to talk about something apart from COVID nowadays. And the main focus of my talk today and the main question I ask is, do women breastfeeding young children with food allergy need to restrict their diet? And in order to answer this question, I asked the most trustworthy source of information of nowadays, which is available, and it is Google. And I went Google, I typed in the question that you've just seen and went for the most popular sources of information. So the first source of information was the blog Ready Set Food. So the blog provided information saying that it's still safe to breastfeed your baby if they have a food allergy, which is good to know. But at the same time, you need to figure out which foods your baby is allergic to and stop eating them for as long as you breastfeed. So this refers to a problem of having food proteins, specific food proteins that you eat that show up in the breast milk, which is true, and we will discuss it more throughout the course of this presentation. The second source of information was related to Children's Hospital of Philadelphia for whatever reason, and it is a source of information provided by healthcare experts. It also states that you need to exclude foods from your diet, but it also outlines that babies can have a signs of food allergy, which includes, as you can see from this website, very non-specific symptoms such as diarrhea, vomiting, colic, eczema, constipation, those that Mike just referred to in his talk. So as you can see, they're very non-specific and they can be attributed to many other causes but food allergy. So this website as well provides information that proteins from those foods that you eat can appear in breast milk within a certain period of time after eating them. And if you exclude these foods from the diet, the proteins will disappear, which is, again, something that we will discuss further on. But interestingly, this is not just a matter of discussion of a very recent time, but it goes back to the much earlier ages. This publication, the American Journal of Diseases of Children by Dr. Ray Shannon, dates 1921, so a century ago. And this is a very interesting paper. I highly recommend it reading. It's a combination of a series of clinical cases and an animal model experiment. There were a few experiments within this paper, and I will just provide you an example of one of the main experiments related to the purpose of today's talk. So in the clinical series, interestingly, the babies that were described were having the same non-specific symptoms that you've just seen on the website that I showed to you, and those non-specific symptoms that Mike just outlined in his talk. In the experiment, Dr. Shannon tried to mimic the potential allergic reaction due to the food protein presence in human milk. So mother was asked to eat egg, and then this breast milk has been preserved for a certain period of time and injected into guinea pigs intrathecally. So all guinea pigs were sensitized, but 2 out of 3 guinea pigs were sensitized. And as you can see, they were injected intrathecally, and the one that was non-sensitized has been injected intrathecally as well. And non-sensitized guinea pig didn't feel particularly well, but it was okay. But 2 others felt terrible. They defecated, urinated, hopped around, and felt absolutely terrible. And then following another injection in 1 hour time, those sensitized guinea pigs died, and the one who has not been sensitized stayed alive. So what's the main message that I take out of this paper? It's actually save guinea pigs, because guinea pigs are cute and nice, but they struggle for almost a century now in different experiments. But it does not really provide with a definite answer that if your baby eats food, proteins present in human milk, they will develop a drastic allergic event. So we are very interested in answering this question. And the question is, what are the levels of food proteins found in the breast milk and how they compare to threshold of reactivity in Ig-mediated food allergy? In other words, does the level of food protein present in breast milk is enough to cause an allergic reaction? And I went from the most trustworthy source of information to the least trustworthy source of information, which is a systematic review, of course, because nobody believes in systematic reviews nowadays anymore. So in this systematic review that is in preparation at the moment, but we went through a number of stages already and finalizing results, we found 32 studies. And when we were looking at those proteins that are commonly looked at human breast milk, are egg, milk, peanuts, and wheat, in this case gliding, because that's the only one that we looked at in human milk. And for the purpose of today's talk, I will just focus on egg and milk. And one of the main reasons behind it is just because they've been studied the most. 12 studies looked at beta-lactoglobulin, although not the main allergenic cow's milk protein, but some looked at casein as well. And of albumin, the egg protein, which been looked at in 7 studies. So in order to calculate the level of protein in human milk and see whether it's enough to cause the allergic reaction, we need really to know how much of a food protein baby consumes in a single go. We looked at the literature, and Kent and colleagues published a beautiful paper. They showed the median milk intake during a feeding in babies of different ages. And we went as conservative as we could. So we went for 216 mils. That's the volume that baby at 13 weeks of life consumes at maximum. And if you're a pediatrician, you know that it's huge dose. It's really a huge feed, 216 mils in a single feed. And we compared it with Vital 3.0. All of you aware of Vital. That's a voluntary incidental trace allergen labeling project, which outlines the levels of food protein which are required to elicit the reaction in a given number of individuals. And the data is extracted from the oral food challenges with confirmed results, which is a gold standard for food allergy diagnosis. And again, focusing just on egg and milk, you can see the doses, the ED1, so the dose that won't cause the food allergic reaction in 99% of individuals and cause just in 1. And also ED5, so the dose which will cause allergic reaction just in 5% of food allergic individuals to this particular food allergen. So how did we make the calculations? I think it's now quite clear. We looked at the concentration of a given food protein in human milk in accordance to those studies that are available, and we multiplied by a single huge feed of 216 milliliters of human milk and compared it with ED1, so eliciting dose in 1% of allergic individuals to a given protein. And as you can see here, that's from our systematic review in preparation, again focusing just on milk and egg for now. This is the total amount of protein out of the whole protein content of a given food. So like beta globulin is 12% of total protein of the whole cow's milk protein. And then we calculated ED1 in mil, so how much of a food protein is needed to be present in a milliliter of human milk to cause an IG-mediated reaction. And I would like to provide with a couple of examples from studies that are included in our systematic review. A wonderful study from Debbie Palmer's group in Australia on eggs, on egg consumption in breastfeeding mothers. So on this graph, you can see the concentrations of albumin, egg protein in human milk, and dynamics since the food intake of one raw egg. But please look at ED1 and particularly ED5, a huge difference. So 32 is maximum on the figure, but actually the levels are somewhere below 12 at maximum, the concentration of albumin in human milk. Whilst to cause a reaction in 1% of allergic individuals, 500 nanograms per ml are required. And similarly, in another study, you can see again the highest levels are somewhere around 4 nanograms per ml, which are absolutely nowhere near this 500 nanograms per ml, which are required to cause an IG-mediated reaction. So looking at cow's milk, you can see the beta-lactoglobulin levels. And again, you see the levels somewhere around 4 nanograms per ml following cow's milk ingestion, and ED1 for beta-lactoglobulin would be 111 nanograms per ml. So again, a huge, enormous difference. And similar in another study, both on beta-lactoglobulin and casein. As you can see, for casein is 241 and slightly above 100 nanograms per ml, whilst 20 is the highest level that we see here, and about 16, 17 for casein. So again, a huge difference. So just to give you a brief example of how much of a human milk baby should consume in order to have a dose of food protein in breast milk to relevant for eliciting the reaction. This is somewhere around 2 pints of beer. So 2 pints of human milk should be consumed by the baby to elicit the reaction. If we're talking about ED1, and for ED5, it's almost a bucket of human milk. So some unrealistic volumes. So the studies that we looked at, out of all interventional cow's milk studies, only 2 out of 10 interventional studies reported levels of beta-lactoglobulin over ED1. That's somewhere between 3 and 5 samples at the most conservative estimations out of 458. So a very, very small number. And out of all interventional X studies, out of 6 interventional studies, we failed to find even a single sample which was above ED1 level. So for cow's milk, it's even though we found some samples above ED1, it's only the probability is only about 1 out of 5,000 to 1 out of 3 over 3,000 babies, cow's milk allergic babies, to have this IG-mediated reaction having breast milk. So the main messages of my talk is that food proteins are detected in human breast milk indeed, however, at very low levels. And these levels are almost always much lower than ED1, which really limits the probability of them being enough to cause a reaction in a large number of infants. And this is, I think, the thought-provoking talk rather than the definitive message, because obviously these results cannot be extrapolated directly into clinical practice straight away. But I think that allows us to think more about importance of food proteins in breast milk, and considering that probably not all the babies should be switched onto infant formula, and not all mothers should go onto restricted diet. And I would like to thank all colleagues, and particularly our medical students that have been involved in this systematic review. And thank you very much for having me here today.
Thanks, Daniel. I'll be brief because I realise we need a bit of time for discussion. So there's a third voting poll to come up. I don't know, Ben, do you want to put that up? So the question for this last 5 minutes is food allergy becoming more common, yes or no? And I'm sorry that it seems like a small number of people can't access the voting, but if you can put your vote in if you're able to access it, that's great. Yeah, and unsurprisingly, we've got 80–85% people said that food allergy is getting more common. So that's a common misperception. So I'm just going to give you a quick 5-minute burst on why that might not be the case. We might be living in an era of food allergy overdiagnosis more generally, and milk allergy overdiagnosis specifically regarding tonight's topic. So these are summary data. These are sort of things that make people think food allergy is getting more common. You've got more auto-injector prescriptions, more people coming to hospital with diagnosis of anaphylaxis, right from sort of early 1990s through to today. But I'd like to put the hypothesis forward that some of those changes could be, social changes, changes in behavior, labeling, concern, etc. Because when you look at the hard markers of food allergy, the objective markers, then the trends are really very much less impressive. So these are the UK data for fatal food anaphylaxis, and it looks very stable. And that's similar in some other countries. There's no sort of obvious rocketing of deaths from food allergy. If you look at allergic sensitization, so again, an objective marker, skin prick test positivity or specific IgE, again, there's not much going on there. These are data from Health Nuts and from a similar cohort in Melbourne from about 25 years previously, showing very similar rates of egg, milk and peanut sensitization across that period of time. Our Isle of Wight data from the UK, again, there's no obvious sort of shift in sensitization to milk. NHANES, large US population-based survey, again, no obvious shift there. So the objective markers are not showing us much. As Mike's already alluded to, milk allergy is a relatively uncommon condition. This is Europreval birth cohorts found just under 1% of infants had non-IgE or IgE milk allergy in the first 2 years. And as Mike's already prefaced, really, there's over-reporting of milk allergy. We saw this very clearly in BEEP, where 14% of English or mothers of English infants reported that their infant had milk allergy. And that was about 10 times the rate of true milk allergy when we confirmed it with challenge and testing, etc. And you didn't really see that for egg and peanut, so it's very much sort of milk over-diagnosis or over-reporting, and not really seen for the other foods. Another way of looking at over-diagnosis is looking at over-treatment. So is there excessive use of replacement formulas for formula-fed infants who've got milk allergy? And the data from the UK suggests that there is excessive use of these products in general in the population. So there's been a doubling or so of use of those products in volume in the last 10 years. You can calculate based on 1% prevalence of milk allergy and known feeding patterns in the country. If you assume every infant is immediately diagnosed with milk allergy as soon as they get symptoms, and immediately goes on to a low allergy formula and uses that throughout the first year of life, then you can calculate how much volume of low allergy formula milks we should be using in this country if we treated everyone immediately with no over-treatment, no under-treatment. And that's about 1 million litres of specialised formula per year. Now we're running at about 10 times that rate at the moment, and the number's not going down. So, based on these little bits of information, it does look like there's, in general, sort of over reporting of milk allergy and excessive use of replacement formula products. And I just want to put this in as a last slide, really, in a wider context. Overdiagnosis has been mentioned a couple of times. It's got a well-recognised issue in healthcare. BMJ have been banging the drums about it for about 20 years. And this slide I've got up there is a sort of classic pattern of overdiagnosis. It looks almost identical to the pattern of anaphylaxis to food that we see at the moment. So you've got a shift in the green line there. This is from thyroid cancer. So the green line there is diagnosis of thyroid cancer from the mid-1990s onwards, and you see this quite steep rise in thyroid cancer in the population. But the clue that might be overdiagnosis is in the dotted red line at the bottom, which is deaths from thyroid cancer, where there's absolutely no shift. And that's almost identical to what we see for anaphylaxis. We see the shooting up of anaphylaxis from the early 1990s across the sort of Western countries, but no shift in deaths or indeed some other objective markers. And I would want to put forward the idea that we might be living in an era of overdiagnosis of food allergy and milk allergy in particular. So I'll stop there and leave it to Hilary to come back with some questions related to her cases.
Thank you, Bob. I'm just going to go back to my cases, and then we present. I think we wanted to show the poll, or did everybody see the poll on the cases? And I wanted to ask the panel how they would actually manage these cases, and then we might go through the chat as well. So can everybody see the polls, Ben, the poll results? No, maybe not. So just to remind you of the 2-month-old baby who was breastfed. So 42% of people said that they would continue breastfeeding but advise trial of dairy exclusion for the maternal diet and reintroduction after a month. And 39% said they would screen for postnatal depression, refer for breastfeeding supports, review eczema, and reassure the mum that it wasn't allergy. So that's quite interesting the way they're quite similar, 42% and 39%. So I might just ask Michael first, how would he manage that case?
Oh, it's me. I wasn't expecting that. So
sorry.
So well, we had a run through, didn't we, together? And
we did. It was the breast baby.
I did plump for D, because I think the key issue here was that the infant was thriving, and it seemed to me that the grounds for positing a potential trial of dairy exclusion, I think, were fairly limited. And I hope the evidence that Daniel has been presenting would just emphasize once again that the rationale for undertaking such an exclusion in a child like this, I'm just not really convinced it's there. So, well, I'll let Bob and Daniel offer their thoughts worth.
Daniel, you might, do you have anything to add to that?
Not really. I would just say that probably I would go with option A, because there's always a chance to switching to option B if option A does not work.
Okay. And Bob, maybe you have a comment?
Yeah, I mean, I think for me, the mistake to make is for healthcare practitioners to say that to that woman, you need to exclude, A, B, or C from your diet, because we don't know if a food is relevant, and we don't. If a food is relevant, we don't know which food is relevant. And based on what Daniel's shown, the absolutely trivial quantities of food that get through suggest that when food is relevant, it may not be allergy. The mechanism might be something else. We know that infants do respond to things their mothers eat. There's nothing new in that. But how much of that is allergy is very uncertain. So I think the mistake for healthcare practitioners is to tell breastfeeding mums that you should exclude this, that, and the other from your diet, because that might help your baby, rather than work with whatever mum's already doing. I don't think we need to sort of try and stop mothers from restricting their diet if that's what they've already decided to do. They've seen a relationship there, but I don't think we really know any better than the mums themselves. That's my comment.
Yeah, so that's interesting. And actually, the reason that I put up this case was because I feel in my clinical practice that I'm seeing two cohorts of women. I'm seeing the women who come in very early on, and then the women who maybe already excluded dairy from their diet, or if they're on a formula, they've gone on to a specialized formula. And often those women will tell me that they're not sure whether the symptoms just resolved themselves or actually the formula made a difference, or the dietary exclusion actually made a difference. So I think as a GP and in primary care, it is actually important to consider what else is in the context. So screening for postnatal depression, or and also, as you said, Daniel, treating the eczema, which is often what the question they have. So I might move on to case 2. So the poll results for case 2. So this was the formula-fed 3-month-old baby, and so 76% voted for ascertaining if the symptoms began soon after introduction of formula, and if so, considering changing to an extensively hydrolyzed formula with reintroduction after a month. So I might ask Daniel first then. Would you agree with that, Daniel, or would you suggest some other treatment for the formula-fed baby?
Yeah, well, I think it really, yeah.
Sorry, apologies.
Yeah, sorry. Yeah, yeah. Thank you very much. Yeah, I think that really I wouldn't go for this baby has changed formula a number of times already, And I think that this happens actually very often. I think all around the world. We just had similar discussions with colleagues from Israel where baby had like switching formula 3 times in 2 weeks. In 2 weeks. So I think that I wouldn't try extensively hydrolyzed formula in this baby, to be honest.
Okay, and Michael, would you have any comments to make?
I think when we were talking about this, Hilary, we want to say it feels that it's. I mean, I'm just interested in you because as pediatricians, we would, if we see this kid, there's such a long wait for them to come through to our clinics that it's usually the whole problem is resolved, no matter what you've done by the time they come through to see us. And I think the big issue here, it's the constant petitioning of the GP to say, my kid won't sleep, that they're miserable. I haven't slept for 3 months. What are you going to do about it?
Absolutely.
And that's where I think in primary care, you have so much a harder time because it's, how many times can you keep saying to them, just hang on, even if you think at heart that's the right thing to do. So this is I think where we're getting into a conundrum, because it's the easiest thing to give you sleep at night as the GP is to acquiesce and say, do you know what, go on, take your tin of whatever and give it a go. And we mustn't forget, actually, interesting, Bob was talking about overdiagnosis, but something I've really been struck as I get old is how powerful the placebo effect is in medicine. How incredibly effective it can be with us giving a family a prescription for something, anything, and telling them with huge confidence that this is going to make a massive difference. And I think that also informs much of the discussion around this. So you only have to spend a millisecond on the internet to see people saying, my kid was in the pits of despair before Dr. X prescribed him, Y, and then it all got so much better.
Yeah, I think that's really important actually in primary care, and we only have 10 minutes to sort of make that diagnosis. And I would say from my own personal experience, and I see it's come through on the chat, that we should always do the reintroduction. On a practical basis, I'm not quite sure that always happens, because I think parents are busy and they may not come back to you, or they don't want a return of symptoms, whether they're caused by allergy or not, and so they just stay on the formula. So I'm not sure that always happens. Do you have anything you want to add there, Bob?
No, just to say, I think the formula fed infant is a bit harder, because I think the downside of feeding, I mean, if you're allergic to cow's milk, then being formula fed is a huge exposure to something you're allergic to. So I think the potential downside of missing the diagnosis is higher in that setting. But I think, those red flags, the thriving infant, it's all quite reassuring. So I wouldn't be going for extensively hydrolyzed formula as the first port of call, but I guess as a battered GP with the parent coming back again and again, then you might give it a shot. Yeah. So I'm conscious that quite a lot of questions in the chat. We've only got 5 minutes. I don't know whether you want to choose one or two there, Hilary, for us to think about.
Yeah, sure. There's been you're quite right. There's quite a few. So one question came in: do we know how much cow's milk protein is needed to trigger non-IgE symptoms? So maybe Daniel might answer that.
No. So okay. probably higher than IgE mediated. But,
for FPIES we've got a reasonable idea, and it's generally a bit higher than IgE. In mild to moderate non-IgE in the Isle of Wight study, the triggering thresholds were 200 mils plus. So sometimes very high volumes. But in general, higher than IgE mediated.
Okay, there's another question here. So still, this from Ryan Murray, still struggling with non-IgE mediated manifestations after this. So no doubt from personal experience, there are children that present vomiting, eczema, excessive wind, particularly with colic symptoms that respond to amino acid feeds with good improvement in symptoms or sleep, and that have failed with typical PPI use. Any advice on these patients and how to manage? Could I ask Michael, do you think you could answer that?
Well, I mean, this is the eternal dilemma, and it fits a little bit with what I said about I said before about the sort of placebo effect. Now, you might argue that would apply to you know, reflux-related treatment, antacids, omeprazole, whatever it is. I just think that when we are contemplating doing these kind of things, the interventions should really be because the symptomatology is clearly, to the best of our ability to judge, really at the, you know, at the kind of the hard end of the normal range. You know, we shouldn't be doing this for soft cases. You know, and then if we are doing it, I think someone else has said earlier, I think that they're talking about the fact it's imperative that it's done on a trial basis and not just carried on ad infinitum. If I can just hijack it a tiny bit, I appreciate we're short time, but Ian made a perfectly reasonable point, using the expression straw man, which I actually had to look up, suggesting that putting putting IgE symptoms into our figure in our paper, he suggested was a straw man, which basically means you're introducing an argument that's got nothing to do with the underlying issue. I think my response to Ian there and to someone else who's said about this is that there were two problems. One is that in EAT, it was extremely hard to even attempt to try and do double-blind confirmations of non-IgE mediated cow's milk allergy. We tried and we gave up. So it was too hard. But the point is, there is good data where people have tried to assess non-IgE mediated cow's milk allergy, that its prevalence is, I think most people would argue, broadly consistent with about the same prevalence of IgE mediated cow's milk allergy. And the purpose of that figure, and I wouldn't like you to lose sight of that, is just to see how disproportionate the different prevalences were shown in that Venn diagram. So don't get too fixated on the exact overlap, but the point is there is such an excess of people suspecting milk symptoms, an even greater excess of children having these normal symptoms, is that we just simply mustn't walk away thinking that every time we see the symptoms, or for that matter, a constellation of symptoms, which is what we're going to show in this little analysis, we've done the EAT data now, that necessarily infers that you've got a milk-related problem.
Okay, interesting. There's a question here I might put to Bob. It says that allergy deaths are very misunderstood by coroners in the UK. Having been to several inquests, this was very obvious, and in each case, after further inquiry and allergy expert input, the coroner changed the cause of death to allergy. Is it very possible that allergy deaths are incorrectly recorded as asthma deaths? Do you think that's possible?
Yeah, that's been looked at in some of the series. Yeah, but it doesn't. Where people have looked at that in the fatality series, there doesn't seem to be an issue there in terms of missing lots and lots of fatal food anaphylaxis. But I agree, any data in this area are imperfect. I think we probably have to wrap up, don't we? We can't really go over the hour, but and I'm really sorry we can't sort of address all the questions and the really interesting issues that people have raised in the chat. But we just I'd like to thank anyway Hilary for emceeing the whole thing and for the very nice cases and queries from primary care. Daniel for calling in at a very late hour from Moscow and giving us a lovely illustration of the science underlying breast milk composition. And Mike, as always, for giving a very thought-provoking presentation about infant symptoms and how much of that might be allergy or not. So thanks very much. Thanks everyone for dialing in, and see you in 2 months' time for the next BSACI webinar.